Doctors, we are live. You can start the session.
So, very good evening to all of you and a warm welcome to the image and video competition felicitation of all the members, of all the winners, sorry, of this excellent competition, which is comprising of some of the most beautiful images which are submitted to the VRSI committee dealing with excellent images. And we are still looking forward for some beautiful videos also to come in. I take this opportunity to thank the committee members with the greatest enthusiasm shown by Dr. Chitranjan, and he's helped in the committee by Dr. Sangeet Mittal, by Dr. Uni Krishnan, and also by Dr. Naresh Babu. I would now request Dr. Naresh to take the proceedings forward for today.
Thank you, Dr. Manisha. Actually, again, we would like to apologize for not having this felicitation program earlier because of the our commitment during that VRSI. So that's the reason why we are having the felicitation for 6 months together. So for this felicitation, like for the last few episodes, we have been inviting experts in the field of VR so that they can discuss the images. And for this, we have got Dr. Subhadra Jalali and Dr. Chandramohan and Dr. Divyansh Misra. So I welcome all for this wonderful felicitation program so that we'll be having a lot of exciting discussion. And to take this forward, our Dr. Chitranjan will be the MC and he will be comparing everything. And as we have already discussed, it will be just a one slide explanation for the images, and we can have a discussion for all these images will be named by Dr. Chitranjan. Over to you, Chitranjan.
Okay. Thank you, Manisha madam. Thank you, Naresh sir. And just to again to repeat what Naresh sir told, we have an excellent panel with us this evening. Dr. Subhadra Dalali madam, Dr. K. Chandramohan sir, and Dr. Divyansh Misra. They need no introduction at all. And without wasting much time, we'll go to the award-winning images. So we know that we are going to display the images and discuss on them starting from the month of July 2024 till December 2024. So to start with July 2024 images, the third prize goes to Dr. Alka Pidaparthi.
Thank you,
So
sir.
this is the award-winning image that Alka has won, which she has captioned as Medusa Gaze Neovascularization in Retinochoroidal Scars. So
Yes,
these
sir.
beautiful images, may I request Dr. Alka to please speak few words about these images. Dr. Alka,
Sure,
please.
sir. Good evening to all the seniors and juniors. So the right side image shows a picture of the fundus picture of a 46-year-old female whose complaint was diminution of vision. Her visual acuity best corrected was 618. So on examination, as shown in the picture, there was a vitreous hemorrhage and a distinct retinochoroidal scar superiotemporal to the optic disc with corresponding pigmentary alterations and a neovascularization over the scar. Though I could not include the fluorescent angiography pictures, it showed that in late recirculation phase, hyperfluorescent tufts with dye leakage into the vitreous. So we diagnosed it as neovascularization associated with retinochoroidal scar, and we injected intravitreal ranibizumab biosimilars post 1 month, which showed visual acuity stabilized from 618 parts to 69. And as seen on the picture of left side, there is a significant regression of neovascularization and resolved vitreous hemorrhage. On further investigating the patient tested positive for cytomegalovirus IgG and IgM antibodies, and the patient tested negative for retroviral diseases, tuberculosis, and her CD4 and CD3 counts were all normal, which showed that she is immunocompetent. So this is a rare occurrence, that is the neovascularization associated with retinochoroidal scars. Since the patient tested positive for cytomegalovirus, the neovascularization might be a complication of a previous CMV-related scar, and the angiogenesis, the underlying pathogenesis might be due to tissue remodeling and a persistent inflammation. So the take-home message is that retinochoroidal scars can lead to aberrant neovascularization, and proper clinical examination and, if possible, FFA and OCTA are crucial in detecting neovascular tufts and leakage. And intravitreal anti-VEGF therapy is a viable treatment option that can lead to regression of abnormal vasculature and improvement of the visual acuity, sir. Yes,
Thank you,
sir.
Dr. Alka. Yes,
Thank you,
very
sir.
nice description. So,
Yes, sir.
my question to the panel, any one of the panel can take this actually. We know that scar tissue can cause CNBM or neovascularization, but it's not very frequent. So, as per their experience, how frequently they see, and what is the like correlation with CMB over here? It is just one association, because we know that in immunocompetent cases also CMB can come positive, but it's just association or it is contributory. Any of the panel, I will request to take this question, please. Yes, sir.
Yeah. Well, I
Please.
have I have to appreciate this because this is one of the largest neovascular membrane I have seen post-inflammatory. Most of the cases that I treated is foveal or parafoveal small chorioretinitis lesions with the extended neovascular membrane, subfoveally or something like that. They regress very well with anti-VEGF. It's not like ARMD things. They regress with one or two anti-VEGFs itself. Sometimes, if the choroidal lesion is active, we do give steroids also, and some of them regress with steroids also when there is an active inflammation. So the take-home message should be: if a chororetinal lesion is there, especially very close to fovea, we have to ask the patient to check the monocular vision once in a while, so that if there is any activity, they should report early, and we can treat the lesion successfully.
Okay, sir.
Okay. Thank you,
Thank you,
sir.
sir.
Point well taken. And regarding the CMB thing, is it just one association? I think we'll take it as it's not like a etiological thing, right?
Yes.
Okay, sir. Yes, sir.
I just wanted to add few points that whenever
Yes.
we have a lesion like this, we need to rule out some very important things. One of the important thing is choroidal osteoma. So choroidal osteomas are notorious for being localized lesions and having very dense and large new vessels. So usually we would like to do a B scan to look for calcification, and even on your
Correct.
OCT to look for calcification there, because that would be a very important differential diagnosis. If you look at the upper part of this lesion, so there's a dense white lesion, and if you see the upper part, no, the other side, the upper
Okay.
nasal
Yes,
side,
sir.
there's a chororetinal atrophy there, just at the
Yeah.
edge. So there is a thick white lesion, which is more white at the arcades. And as you move upwards towards 1 o'clock, that area has
Yeah.
some chororetinal atrophy with some pigmentation, which is very unusual in CMV retinitis. That
Correct.
shows that it's more of a, like a degenerative
Mhm.
lesion. The other very important differential diagnosis, so, your FFA may have picked that up, but B scan will pick up the calcification. The other very important differential diagnosis would be a retinoma, a spontaneously regressed retinoblastoma, or even a spontaneously regressed retinoblastoma, which is now getting activated. So again, looking for calcification on B scan and very carefully looking at those lesions with contact lens or a more magnified view would help us just to keep that in mind, because we have seen retinomas converting to retinoblastomas even in adults, older people, and they can present something like this. They usually don't have the excavation part, but we never know. So I think these are two
Correct.
important differentials. And of course, we should always ask history of any trauma, because the traumatic scars again are very notorious for getting neovascularization. And if there's a childhood trauma or there was some scleropateria type of trauma, which this patient doesn't have, but I'm just saying that these 2-3 histories we should definitely take, and a B scan to look for calcification would be an important consideration. I don't think the patient has any signs of CMV as such, and many of us can be positive for CMV, and all the
Yeah.
counts are normal, so that means that
Yeah.
it's not there. You also have
Yeah.
mentioned in your slide that patient had some metamorphopsia. So that will be nice to know on OCT whether there was some fluid in the macula, because
No, ma'am.
there
OCT
you would,
macula was done, ma'am, and it
yeah,
was quite normal.
yeah, because you've
There
written
was
visual
vitreous.
distortion.
So
Ah,
whether these are just the floaters which are causing that visual disturbance and it's not a distortion, but usually if there's no fluid, then it could just be the vitreous hemorrhage which is causing visual disturbance. Very nice case, great case.
Thank you.
thank you
Thank
very
you, ma'am.
much.
So point is very well taken that we should keep choroidal osteoma and retinoma are two differential diagnosis. And in addition to FFA, the B scan and OCT will also help us in this. And also, yes, traumatic choroidal scleropeteria or trauma history is also a remote differential.
No,
So
I don't
thank
know why
you, madam.
laser was done. Why was laser done? Go back to the picture.
Because there was neovascularization, we just thought of like we wanted to control that, so we have done laser around the
So the
scar.
laser has been done in the periphery, so that's really very unusual because see that will increase the scotoma and patient is looking down, so it will
Yes.
influence their inferior vision. So even if you wanted to do laser, maybe I would have just done it on the temporal part. Whereas the
Okay.
nasal side, where you have just extended, so now the scar has got extended with another scar.
Yes.
That's that I would not have done. I would also have possibly done the laser, but I would have done it more within the scar and at the edges and just
Okay.
on that side and
Yes, ma'am.
left
Okay.
this side, untouched because there's no pathology on that side. But it's
Yes,
fine.
ma'am.
It may
Yes.
or may not
Okay.
be doing something, but it's fine.
Okay.
One more thing can I add, Chidran? So the
Yeah,
acquired
Divyans.
astrocytic hamartoma can also present as neovascularization, and because as madam is also suggesting, the lesion looks elevated. So obviously we do not have a three-dimensional like a OCT or a B scan to give us the feedback, but the inferior lesion over the arcade looks elevated, and when it is resolving, also there is some calcification. So there is some dystrophic calcification which is occurring. So as madam has suggested, I really second the thought of both retinocytoma and the first, which was choroidal osteoma. The third, which I feel maybe acquired astrocytic hamartoma, but yes, the OCT passing through the lesion could have given much more information, but yeah, very good documentation otherwise.
Thank you, sir.
So thank you, Divyans. So again, Dr. Alka is a medical officer in Sankar Netra Chikitsala, Eluru. Congratulations, Dr. Alka, and
Thank you, sir.
she wins a certificate and 2,000 rupees.
Thank you, sir.
Yeah. So with this, we'll move to the second prize, Dr. Maheshwari. So this is the award-winning image with a title "Spotlight on Shadows: Vitreous Cysts in a Patient with Retinitis Pigmentosa." This very beautiful image captured in Jais Claras. That Maheshwari is a medical officer in ASG Eye Hospital, Mysuru. May I request Dr. S. Maheshwari to please describe this image? Yeah.
Good evening, all. Thank you for the opportunity. So this was a case of a 49-year-old female patient presenting with chief complaints of night blindness, progressively worsening over the years. Her best corrected vision acuity in the right eye was hand movements and left eye was 5/60. Examination showed PSC in both eyes with fundus examination showing features of retinitis pigmentosa. But in the right eye, the patient showed a feature of idiopathic vitreous cyst. So I presented this case for the same. To confirm that it was idiopathic and not any kind of pathogenetic like cysticercosis. We did B scan to see if there is any scolex, but nothing significant was noted. So the patient was just kept under observation.
Yeah, so sometimes very benign things like this also can get us awards in competitions. That's a very great message from this. Any panel wants to add anything to this image, please?
Yeah, I only wanted to say that you have mentioned that it is rare. Actually, RP is one of the more common conditions where almost 6 to 7% in the literature are known to have vitreous cyst. So actually, if you have vitreous cyst, you should look for RP. And mostly we see it in this phase when it is very advanced RP and we see this vitreous cyst. And of course, the other thing which will help you to differentiate it from a cysticercosis is the size, because it's quite encapsulated and small. And usually the active cysticercosis will move with the movement of the light. Whereas these cysts, they freely float, but they don't contract and expand with the light. If it is a dead cyst, then usually there'll be a lot of reaction. If it is a cyst, so there'll be a lot of vitritis. RP patients can also have some vitritis, vitreous cells. So these are some of the points one would, differentiate. But The RP is very well known to have both the disc drusen, hematomas, astrocytic, and these vitreous cysts. Yeah, but it's very beautifully captured.
Beautiful capture.
Thank you.
So, anything, Dibyan sir, KCM sir, you want to add?
So
Initially, it looked like a small nucleus which has dropped in, but as Madam told very clearly, if it is associated with vitritis, then we should consider the differential diagnosis what Madam had already told. So if that will confuse with RP with vitritis with cystic sarcosis, so we have to be clinically careful. That's the only thing.
Yeah, correct.
just some clinical pearls for this is there can be congenital cyst or the acquired cyst in a retinitis pigmentosa. Usually it's an acquired one. It can be a non-pigmented and a pigmented cyst. So in this case, again, the pigmented cysts are more common, as Madam had also suggested in RP. So very well documented, yeah, as Madam has suggested, not very uncommon, but yeah, high association with it. But
even it can be bilateral in RP, it is not uncommon to see bilateral.
Correct. So again, congratulations, Dr. Maheshwari.
Next.
She wins 3,000 rupees and a certificate. So with this, we move to the first winner of July, Dr. Sachit Mahajan.
Thank you, sir. Thank you.
Dr. Sachit is VR fellow in Shroff Charity Eye Hospital, New Delhi, and this is the beautiful image with the title "Eyes Never Lie," for which he has got the first prize. And may I request Dr. Sachit to please explain this image, Dr. Sachit.
Good evening, all. Thank you for this opportunity. So this is a fundus photo of a 42-year-old female who presented to us mainly with the chief complaints of blurring of vision in her left eye. So when we examined the fundus, we could see that there was a bullseye maculopathy-like lesion in both the eyes with ERM in her left eye. So when we asked about any medication use, she told that she has been using cloimipramine, which are tricyclic antidepressants for past 1 year for depression. We did a fundus autofluorescence and OCT for this. In fundus autofluorescence, we could see that there was a central hypoautofluorescence with a surrounding rim of hyperautofluorescence, signifying the bullseye maculopathy-like lesion in her both the eyes. And now we have asked the patient to go back to her physician and ask about any drug, and we could not find any association of tricyclic antidepressant with bullseye maculopathy-like lesion in literature.
Now, what about the lesions which are surrounding those black pigments, and there are pigments all over an RP atrophy?
These were
In the
present.
inferior half,
Yes,
yeah,
ma'am.
this one, and then the superior also. Outside the macula.
Yes, ma'am. They were present till mid-periphery, ma'am. These lesions, ma'am.
Yeah. So see, what is the important is the differential diagnosis, that we have to rule out retinitis pigmentosa or a cone rod dystrophy because of all those pigments and the arterial narrowing. So an ERG, full field ERG and a multifocal ERG is very essential to say that disease is only in the macula or is it involving the whole retina. And of course, we don't have the full fundus picture. It would have good to have the full, wide field picture to say that it is only a maculopathy, because the, the Robson Holder ring,
yes,
which is very famous for RP, will look exactly like this.
Yes, ma'am.
And for us to say that this is drug-induced maculopathy and not a retinal dystrophy, we should have the fields, visual fields. So if it is drug-induced maculopathy, the peripheral field should be totally normal. So even if you don't have ERG, but fields we can do. Because if the peripheral fields are showing ring scotoma, then we will not usually think of drugs. Now, it can be that a patient of retinal dystrophy can be on a drug and it can worsen the dystrophy also. And they may be more prone. That is, there's not too much of literature on that, but there is some thought process that if patient already has a retinal dystrophy, then don't put them on medications which are likely to cause, because it may accelerate the disease process. We don't know that. But in this type of case, I think always whenever we say drug-induced, we have to rule out, especially in our country, where the dystrophies are so common, the consanguinity dystrophy, the close marriages, even those who don't marry in close relation, they still marry in their own subcaste. So still there's a lot of gene, pooling. So I would, be skeptical to say, because there's also temporal disc pallor, patient has small discs. So I would really like to see fields and or electrophysiology to say that, we are dealing with drug toxicity and nothing else.
Okay.
But I really like the way the lower two pictures have been put together. They just look like two eyes. The way you have put, no, they look like two
Yeah.
bulging, beautiful eyes. And in the center,
Yeah.
it seems as if it's
So
the
correct, ma'am.
glabella. And this is some sort of, nasal nose in between. So the way it has been put up looks really very stacking, looks like a owl's eyes. Very nice
So
composition.
yeah, Dr. Sachit has put all his efforts to make it very artistic. So we must thank him. But simultaneously, as Madam has told, we should see the wide angle view kind of the fundus. Additionally, the electrophysiological test and also the visual fields, which are very important to rule out any dystrophy in these kind of cases. So very good
Also,
information for
history,
all our viewers.
most of the drug maculopathies, they will have, because they have more of cone involvement, they'll have more of color vision loss and photophobia or
Yeah,
things like that. Whereas,
correct.
in other, you will have more of night vision problems. So those symptoms are very, very important to ask. If we don't ask, patient will not tell.
Yeah,
Of drug is also important. How many years he is taking the drug, because it's not idiosyncratic, it is dose related. So
yeah.
it might take a long years to it. So how many years he is taking the drug is also
1
very
year.
important. 1 year.
One,
One
sir,
year is a
1 year.
short period to
One
have
Yes.
such a
short period.
diffuse changes in the mid peripheral retina and all.
Like HCQ, it is written that 1000 grams, like
Yeah, drug
the cumulative
duration
dose should
dosage
be,
is also
yeah,
important to say that it is
10
drug
years.
related.
Yeah.
It's
So
a good
just
good picture to see. That's
good
Yes.
picture, really.
so picture has attracted the first
Yeah.
prize for him.
So again, congratulations, Dr. Sachit. He wins 5,000 rupees. With this, we'll move to the award-winning images for the month of August. So first, the third image, third award goes to Dr. Rajiv Gandhi. So Dr. Rajiv is a medical officer in Anupam Eye Hospital, Cluj, and this is the beautiful image, suspected VHL disease for which he has got the award, and this is the description he has given. May I request Dr. Rajiv Gandhi to please
Good evening,
describe this
everyone.
image?
Yeah,
Yeah,
this
please.
was a 21-year-old female which presented with defective vision in right eye since last 10 days. She had no other history. So on anti-segment was normal. On fundus examination in right eye, there was superior temporal dilated vessel with a solitary lesion which was protruding into vitreous with few vessels, dilated vessels around the base. So she underwent fluorescein angiography, which showed a hyperfluorescence and mild leakage at the base of the lesion. So I suspected this VHL and I had asked her for a MRI and MRA. In MRA, there were a few cyst-like dilated vessels seen in the brain, but there was no leakage or any other lesion seen. So it was an isolated lesion and suspected one VHL disease. On OCT, she had a macular edema. So she underwent an anti-VEGF injection and the edema resolved after one injection. Since then, she is doing fine. Generally, I had asked her to undergo laser for the fitter vessel, which shown leakage on the FA, but then she refused to undergo laser. But since last 1 year, I'm following up her. There was no recurrence of edema. So this was labeled as a VHL disease, von Hippel-Lindau syndrome.
Okay. So, like one question to the panel here, it will be whether to go with anti-VEGF injection or steroid or laser to the lesion directly for macular edema in these kind of cases.
So I had published a series of cases. It is available in Documenta Ophthalmologica that I published as a fellow. Influence of peripheral retinal vascular malformation treatment on the macular pathology. So if we treat the periphery, in those days, of course, there were no injections. But it was like if we treat the macular pathology, the peripheral pathology, what will happen to the macular lesion? That's a very nice paper. You can go through that. So what we found that almost 90% of the macular pathology, including ERM, including hard exudates, including macular edema, cystoid macular edema, everything resolved just by treating the peripheral lesion without doing anything to the macula. But only thing is, in a lesion like this, what we have to be careful is to not treat the feeder vessel, because that will, so we have to treat the feeder vessel, but first we should surround the lesion, go slow, then slowly treat the artery, then treat the vein. So like it has to be a very staggered, slow treatment, because this lesion already has some fibrosis. So that is what we are concerned about, that it may cause a tractional tear or there can be a fibrotic tear. So I think today with the anti-VEGF, if we have given anti-VEGF and macular edema is gone, and I'm sure that dilated vessel would also have reduced, and we are keeping under follow-up, that's also okay. But we should do serial photographs to see whether the lesion is increasing and whether the fibrosis, because it may smolder and it may not leak now, but it may cause more fibrosis over a period of time, and then that will cause a very difficult detachment to manage, if the fibrosis increases, and it may be better to treat it now rather than later. But yeah, serial evaluations and documentation of the size of the fibrosis especially would be, and the vitreoretinal traction. But if we treat the peripheral lesions, whether they are of Coats disease or they are of von Hippel-Lindau, or even in that series, I had put one patient as unidentified because that time I didn't know what that patient had. I'm happy I didn't write some diagnosis. I just wrote an unidentified vascular disease. Today I know it was FEVR because she was blind in other eye. That time we didn't know FEVR. So yeah, we showed even the hard exudates resolving. The only condition where it did not go very well was adult onset telangiectasia, parafoveal adult onset unilateral telangiectasia, where in spite of multiple treatments, still the macula kept on worsening and it didn't do good.
Okay. Divyans, you want to add anything, because I am sure that your center you are treating lot many cases.
So to rule out the systemic association rather than going for an invasive modality, getting a VMA test, a simple VMA test would be very effective, 24-hour urine, and then get the VMA association, because very high chance they may have a nephrology involvement, and getting ultrasound B scan of, because getting angiomas in the brain does not happen simultaneously, but yes, over a period of time it does happen. And managing such case, as Madam was suggesting, fibrosis is one of the issues over there. So, I mean, just a way out of thought, maybe probably to do a buckle and then do a laser rather than doing direct laser, because laser itself, as Madam was also suggesting, is going to increase the fibrosis. And as the sequelae, we know that it may land up into a TRD. And then the worst part would be the CRD because of the laser breaks, which would happen around that traction. So that would be one additional thing. And treating such cases ideally would be to repeat FFA in a frequent intervals, because clinically the vessels may not look dilated, but there can be small angiomas where you can completely nullify the occurrence of this kind of large angioma if we are treating at the right time. So how to identify that is by doing a wide field FFA and then identifying those small angiomas and treating them, because right now this is already a kind of a difficult angioma to treat, as Madam is also suggesting, because the sequelae, as we know, would not be good for the patient. And obviously, the other eye is also having a risk. If there is a doubt, getting a genetic analysis and a VHL association would be the most ideal, because we are thinking it is one unilateral, but there can be sequential involvement, not right now, but probably 3 years together later when we see the patients, we understand that there are newer angiomas in the other eye, and familial, because very high chance of autosomal dominant association. So that's why familial or the parental and also the sibling screening is very important in such cases.
Thank you, Divyans, for a very
Just
good
one
elaboration.
question. Can I ask one question? Can this
Yes.
be
Yeah.
vitrectomy can be done and excised as it is a solitary? And
So my advice would be no. I am not a proponent of vitrectomy in such case. I would go very conservative. As I told, I would think of buckle probably at 279, at 280, and then probably I would not advise personally.
Yeah, so I think we should go rather more conservative than very aggressive in this. Yeah. So again, thank you. We had a very good discussion on this image, and again, congratulations, Dr. Rajiv Gandhi. He wins 2,000 rupees and a certificate. So coming to the second winner, Dr. Shama Sharif. So this is a very beautiful image intra of screen graphs he has taken. So we can see there is a one lens, there is CTR, and also there is a coloboma. So you need to really think of something artistic during surgery to take this kind of image and also get one award. So again, congratulations, Dr. Sama. May I request, if she is there, she can explain this image or tell further. Dr. Sama Sharif, please.
Yes. Good evening, sir. Actually, this is a 70-year-old patient who came 20 years post cataract surgery with the vision drop. On examination, we saw that he had dislocated IOL with the CTR around it, and he had a retinochoroidal coloboma. So my dilemma was whether there's gonna be an intraoperative RD. Since I did not have a wide angle fundus photography, this is an intra-op still of the patient. But since I observed that there was already a complete PVD and there was no any ICM detachment or RC edges were clearly observed, since there was no any break noted, I did not even do an endo laser for this patient around the coloboma, and it's been 1 year post surgery, and patient is still doing good. And the procedure that was done was IOL removal with the CTR removal, and scleral fixated IOL was done for this patient, sir.
Dr. Sama, very nicely done surgery. I have one question. Did you remove everything in toto? That means the IOL CTR complex, or
No,
you
sir.
kind of, yeah,
I first removed the CTR.
yeah,
When I actually, it was attached to the IOL. So first I
yeah.
actually removed the connection and then
Mhm.
removed the CTR first, followed by the IOL, and then did the SFIOL, sir.
Correct. So my question to the panel, do they differ? Like Dr. Sama has done a very nice job. Do we sometimes get tempted to remove in toto, or sometimes the CTR to cut it and take it in two halves or anything? Any comments on that?
Removing in toto will be slightly difficult because the CTR will not be flexible. It's not a flexible thing. It's a rigid one.
Yeah,
So
yeah,
we need a large incision, and it is more traumatizing. So it's better
yeah.
always what she has done to separate it from remove, or you, as you told, you can break the CTR into two pieces. With the cutter also sometimes it breaks, and then remove in two pieces. So not to remove in a toto because it's more traumatizing. That's all.
And sir, if at all we are separating, then we can fix this lens also. This is three-piece lens. Can we
Yeah,
go for that? We can go for that. No?
yeah, that
Just
also
a
can.
thought. That's
Internal
all.
fixation of the same
Same
lens
IOL.
can be done. Yeah.
Yeah.
So just I was thinking that we could have refixated the whole complex
Both
itself because the
complex also
CTR.
can be done. Yeah.
So
Even with
because
CTR lens also can be done.
that's so. What was the corneal diameter? Because usually the corneal diameter may be less because
Yes,
taking it out again larger incision. So that's why. But very good surgery. Finally, in the hindsight, we can talk about multiple things, but very well managed.
Yeah. Correct.
but I
Thank
could
you.
have done endo laser to the coloboma since we are always inside. But it's okay.
That was one debatable this for this case, sir, whether to do
Yeah,
an endo laser for the edges or just let it be. But like
right.
for God grace, patient is doing good, sir.
Yeah, if
I
TP Das
just want
article.
to comment on that about the laser to coloboma, because I think I'm one of the few people who really advocate a lot of lasers. But I would just like to say that this type of coloboma, which is very smooth, round, without any intercalary membranes, these hardly ever cause detachments. And this is one group of patients where I almost never do laser. Of course, if I was inside the vitreous cavity, then I might have just put 2 rows. But generally, this is the type of coloboma which I say just leave it alone. It doesn't cause detachment, because all the detachments that we see, we hardly ever see this type of coloboma with a detachment. Now, the caveat there is we don't know the population-based data of different types of coloboma, type 1, 2, 3, 4.
Yeah.
So, but in general, whatever patients come to our OPDs, and all of you would have seen that, this type of coloboma is less common. it's not the commonest type. Small ones, little bigger ones, little more bigger ones, and they almost never develop breaks in the edges, which are very common in the other types of colobomas. And so you are okay to leave it alone. But even if we had to treat, it would not have influenced the visual outcome because it's not close to the disc or macula. So somebody wants to put 2 rows, it's okay. But if you don't treat, you're absolutely okay. Because actually sometimes, especially when we have not removed all the vitreous there and vitreous is adherent there, actually your laser probe may get entangled into that vitreous and it may cause more problem. So I think you did good. Less is good. There is no indication for laser while doing the surgery. You didn't find any detachment. I think just leave it alone. Sometimes when we try to do more, we may get into more trouble.
Trouble. So again, congratulations. That is Sama Sharif. She has done a very nice job. She is medical officer in the Eye Foundation, Madurai, and for this beautiful image, she wins 3,000 rupees and a certificate. Congratulations. So with this, we move to the first winner, that is Tejaswita Verma. So this is a very beautiful image. We can see idiopathic giant retinal tear. We can see it is just looking like a velvet cloth kind of thing, something. The retina and below the choroid, we can see very clearly, very nicely taken with very good resolution image. That Tejaswita is a fellow in Retina Foundation, Ahmedabad. May I request her to please describe this image?
Yes, sir. Sir, this was good morning, good evening, everyone. This was a intraop image taken. It was a giant retinal tear which was spanning more than around more than 270 degree, nearly 360 degree, and it was captured after doing the core vitrectomy and clearing the vitreous around the edges. And then PFCL was injected to iron out the retina, and then laser was done, 360 degree, and endo laser was done, and then oil was injected after the fluid air exchange, and positioning was given post-op positioning. 1300 centistoke oil was used.
So as we can see, there is nothing novel. Like they have done a good surgery, surgical part. It's a very successful surgery. But regarding the imaging, uh, comments or compliments from our panel regarding this image. This is the intra image, and I believe Dr. Tejaswita, this is with a contact lens.
Yes, sir. It is with a wide field contact lens.
Wide field
Yes,
contact
It's
lens.
looking like a beautiful lavender flower.
Yeah.
There, the color. And I'm also very happy to see, we can see through the fold that the macula is almost attached because we are seeing a very good foveal reflex.
Yes,
Which means, the macula was attached, and that's really so nicely brought up in this picture. And also this picture is good for, training the residents and students, fellows, like, how do you make out that, we are seeing the inverted flap, and if it is inverted, how the retina will look through that. Because sometimes people mistake, retinal folds, especially when we see ROP or TRD, that it's only a retinal fold and there is no bare choroid.
Yes.
People just write bare choroid. Actually, that's not a bare choroid. It's just the drag retina. So when there is bare choroid, which we see here, this is what it will look like. So to differentiate a stretched retina where it is attached with some choroidal changes and a detached flap where there is bare choroid, this is a very nice picture to teach so many concepts about attached macula, foveal reflex, the folds, then that pigment at the edge, which you can see at the, at the fold of that pigment is there where it has detached from the aura.
Yeah.
So many nice findings are there, this one. Yeah.
Yes.
So I think, to teach the fellows so many findings, it's a beautiful picture.
So as Madam told rightly, she has actually combined the art of imaging plus the science of ophthalmology, rather retinology. So great image. Again, congratulations, Dr. Tejaswita. She wins 5,000 rupees and a certificate for this beautiful image. And with this, we'll move to the images for the month of September. And the third prize goes to Dr. Cecile Varghese. So Dr. Cecile is a very well-known figure in retinal imaging. He is medical officer in Amit Eye Hospital, Tiruvalla. And this is again a very beautiful image, what lies beneath. he has given the caption, and we can see this is a monochromatic image with the IOL in the inferior fundus. So this is the text he has given. May I request Cecil to please describe this image? Cecil?
Yeah, thank you, VRSI panel and esteemed seniors, and thank you, Dr. Chitranjan. So this was basically, I mean, we encounter these situations day in and day out in retinal practice. So this was a dislocated IOL back complex, but the only thing here was it was in a 68-year-old male who has undergone vitrectomy for proliferative diabetic retinopathy, and extensive laser and everything was done. So this was just to highlight the fact that post vitrectomy, and also this patient had an additional risk factor of pseudo exfoliation. So in such patients post vitrectomy, when the vitreous support is gone, you need to be extremely careful, have a good follow up, and you can have this kind of a dislocation or a subluxation of the intraocular lens. So in this case, it was a little extreme, and it spontaneously dislocated into the vitreous cavity. That's why it's completely lying free down onto the retina, because there is no vitreous at all. So this was, I took actually a color image, then I just made it a little red free, tweaked the contrast a bit, gamma correction, and then you could see these nice, beautiful, even the choroidal vessels. You can actually appreciate the vortex veins and all in this image. So yeah, that was the main highlight.
Yeah, looks like a moon with a starry sky.
Yeah, yeah,
Thank you.
correct. So for the sake of all the viewers of this beautiful event, actually you see, maybe you will tell, "Arey yaar, kya hai?" So we see day in and day out, like you will tell. But see the imagination what he has put. He took a color fundus photo and immediately he thought, okay, if I take it a red-free image, it will look more artistic and it may fetch one award for me, which he eventually got it. So sometimes we need to open our artistic brain also while doing these clinical activities in the OPD. So again, very nicely done. Any other comments from our panel on this?
No, the changes he made is showing all the treatments, highlighting all the treatments that have been done before. Nice focal
Yeah.
laser marks are there,
Yeah.
and
Yeah,
nice
yeah,
PRP. So it's highlighting the old treatment that has been done.
yeah,
So
correct.
it's the award is for the artistic skills he has shown on the photo.
Yeah,
So
Highlighting.
also, these laser marks, if you see, it is so many years after the surgery. Usually when we
yeah.
do the laser, they will not be like this. They'll be
Yeah,
round.
so
But we can
There
see
are
how
some
these marks
expansion,
have expanded and
expanded.
coalesced and
Yeah.
changed their character, and how the underlying retina has become atrophic.
What fundus camera? This one, Cecil?
So this was taken with the Nidec Mirante.
Okay, good, great.
Okay.
So again, a very nice image, and congratulations, Cecil. He wins 2,000 rupees and a certificate for this. And with this, we'll move to the second winner, Dr. Nikhil K. Dr. Nikhil is medical officer in Jyoti Sai Hospital, Kannur, and this is the beautiful image he has captioned as tree and trough in the eye. We can see the fundus photo, and this neovascularization is looking like a kind of tree, over here. So, Dr. Nikhil, can you please explain this image?
Hello.
Yeah.
Good evening, all the panelists and Dr. Chitranjan and all the other delegates. She was a female. Both eye. I've done PRP laser in both eye. Or she was on regular follow-up. She had this tree-like fibrovascular proliferation at a disc in the left eye. So when in the serial follow-up, one day I noticed the secondary macular hole. So I took her for a vitrectomy surgery, and I did ILM peeling and peeled off this all the membranes, and the hole closed. Pre-op the vision was 636, and post-op it improved to 612 in 8 kind.
No, Nikhil, you tell about this imaging part. You told nicely I've done the surgery. We don't have any doubt about that. This
Okay.
imaging, from where you got the kind of that artistic thing? Yeah.
This wide field imaging is done by eye care IDON wide field ultra wide field imaging fundus camera.
Yeah,
Correct.
there's
So
VRVO in the upper part.
yeah, correct. We
So
can see the sclerosed vessels
yeah,
over here. Correct.
that's why that pathology is, persisting.
So if you people will be following the cover page images, this month ophthalmology cover page images by Kushal Deliwala. He is one of the again avid imaging person. He has got one image just similar to this, a kind of falling tree kind of appearance, and that is in cover page of ophthalmology journal. So what I'm telling, sometimes the neovascularization of the disc, they can be taken artistically and they can be documented very well. So well done, very well done, Nikhil. Any other comments from our panel?
Thank you, sir.
Anything?
Sometimes some of these lesions could also be a manifestation of a persistent fetal vasculature stalk, a persistent hyaloid, which then gets
Correct.
opened up, and we have a whole series of things, not for diabetic or PDR, but sometimes they may be, if we see carefully, like is it closer to the posterior part of the lens or closer to the Burgess space or at the anterior hyaloid, is it attached to the anterior hyaloid or not? So that's also something one can think of. That
Yeah.
is it the patient already had a persistent hyaloid system and now it's sort of opening up later in life because there's ischemia all around and it's asking for more blood. So
So
sometimes we
point
see
is,
that in.
yeah, very well taken. What Madam told, we should see the anterior extent of this kind of neovascularization or tuft, whatever is there. We should see that. So again, congratulations, Nikhil. He wins 3,000 rupees and a certificate. So with this, we move to the first winner, that is Sarath Hegde. So again, Dr. Sarath, a very good friend. He is medical officer in Prasad Netralaya Super Specialty Eye Hospital, Udupi. And this is the beautiful image for which he has got the award, multiple black spots in OCTA. You can see over here. Sarath, can you please tell about this image?
Thanks, Chittaranjan, for this thing. So this case patient was a 10 years old female who came with just a general follow-up because she was hypermetropic of around +4 in the both eyes, where which the vision was improving to 20/20. So when they saw these images, they referred to me, and on fundus photograph, you can able to see there are like multiple blackish pigmentation or in the outer retina, the choriocapillaries, which looks like a bear track pattern in the part of it. And I did a autofluorescence, and this image was the similar picture was there in the other eye also. And then when I did the autofluorescence, it was hypoautofluorescence. So I just wanted to see how the OCT angio sees, so that what level it is there I can able to see. And the OCT angio when I did, and the choriocapillaris slab, it shows multiple nice I can say hypo lesions in the in that area where the RP pigmentation was there. So this is a case of group type congenital pigmental anemia of the RP, which is also called a bear track appearance. Sometimes if there is a multiple atypical type of comet shape RP changes are there, then we have to suspect familial adenosis also, which can be associated with it. So I just observed this patient. I didn't, I just sent it to gastroenterologist for any association of adenosis polyp. Thank you.
Thank you, Sarath. Very nicely done. And really to think about doing some unfast OCTA at the choriocapillary level, giving some time over there near the OCTA machine is really great, and you've done a nice job.
I just
Comments or
wanted to
compliments?
ask how many, I just want to ask, are these lesions elevated also? Because if we see the superior vessel, it seems to be, yeah, this one. So
It's a
this,
reflection, ma'am. It's not elevated. It's just
yeah,
because
no,
it's
no, if
hypermetropic,
you
the
just
reflection
come
was
little
there.
down, then
Yeah.
there is a, there's a curve to these
There
vessels.
are like multiple whitish folds are there in the near the macula. You can able to see the inferiorly, slightly
Yeah.
inferiorly, the multiple white lines which
Yeah,
can be
even
seen.
in the fovea, we can see those
Yeah.
some retinal
But
white lines.
OCT wise, there was nothing, no folds, nothing was there in that area. Both eyes had a similar picture.
Correct.
Yeah, maybe it is due to hyperopia. I don't know.
Yeah.
So hi Shad, very nice image. Just question. So this whitish kind of lines which are like congregating at the macula, is it bilateral?
Bilateral. I don't know what it is.
Is there some collagen vascular disease which is causing this? Means Ehlers loss means not that
Actually, when you
kind of.
see this, I thought there is some folds or retinal folds maybe there or some elevation maybe there in the choroid. but the OCT is showing intraretinal hyperreflective this thing in the OCT. I can share the image, Chitranjan sir.
Yeah, no, we can,
That's
like,
late.
we'll discuss it sometime
Late.
later.
Yeah,
sure.
Yeah.
But it will be nice to have the biometry, like, the A scan.
Yeah, biometry was plus
The
20,
corneal
plus
diameter.
20.50.
So that will come into
length.
that will come into the nanophthalmic, posterior microphthalmos spectrum if the corneal diameter is normal.
Yeah.
So it will be nice to see the other, the corneal topography and the lens thickness
Correct.
and the AC depth to see whether it's nanophthalmos or posterior microphthalmos. And nice, I think, little more information.
Correct.
Okay, go ahead.
So yeah, so again, congratulations, Sarath. He wins 5,000 rupees for this beautiful image. And with this, we move to the images for the month of October 2024, and the third winner is Dr. Sriram Simakurchi. So this is again another beautiful image, vitreous wells, a tail of floating vessels. We can see over here very nicely. Actually, in the periphery, how many times we will put effort to capture such a beautiful image. So Dr. Sriram, if you are there, can you please tell us more about this image?
Good evening, everyone. So this was a case of an 8-year-old female child who was brought by parents with sudden complaints of diminution of vision in one eye. On examination, she had a vitreous hemorrhage in her right eye, and left eye had, on examination, I was able to detect a retinoschisis cavities with inner retinal holes and thin atrophic retina, inner retina. And we can see two blood vessels. One hardly has any inner retinal tissue, and other vessel has very thin strip of retina. So I thought to label it as a vitreous veils. The image was taken by Topcon DRI OCT machine with a plus shift, so that the focus can be anterior to the retinal plane. Patient underwent vitrectomy in the vitreous hemorrhage eye, and 2 years follow-up. The child is stable in her left eye. There is no breakthrough bleed in this.
Say that again. How did you take the image?
Madam, in Topcon machines, there are three modes. 1, 0, which helps in taking images from -5 to -7 to +7. Then there is a plus mode, which helps to capture images in patients with +7 to +15, if I'm not wrong. And there's a minus mode that enables us to capture images with up to -15 diopters of correction. So the anterior, here the blood vessel which is anterior to retina was captured by shifting the focus into plus mode.
Great,
Okay.
great.
Great. So again, for all our viewers, we must have this kind of, the technical information with us. So he has focused exactly where it should be focused. These blood vessels, which are like actually like pillars, and the vitreous, and the background is blurred. Just like in movies, we see the cameraman focuses on one character and the background is blurred. So great image. Any other comments, Divyans or KCM sir?
Good image. That's the only thing.
Dr.
He had anything done, Tiram? Barrage or anything to that area? No, just observe.
No, sir. In left eye, since there were no outer retinal holes, even a examination under anesthesia was done. So considering the risk of rupture of a vessel or retraction, it was.
Yes.
Correct.
So, Dr. Sriram sir, just two more questions. Very nice, beautiful image. One, that what was the duration of vitreous hemorrhage?
Around 1.5 months, sir. Like patient came
1.5
to
months.
Hyderabad unit, but
Okay.
surgery was done by Mahesh sir at Bangalore unit.
Okay. Because one of the cases which I am managing, having retinoschisis and having vitreous veils, so there are multiple pathologies associated with this kind of vitreous hemorrhage. One is the active traction at the edges where we can see this naked blood vessel.
Yes,
because the cortical vitreous is still attached to the this anterior like the sciatic retina, and because of the rapid movements there can be avulsion of the blood vessels. So that is one. And the second is that the outer retina is usually less perfused, and that's why it acts as like a CNP area, and we can see a new blood vessel formation which is into the vitreous cavity or an epiretinal new blood vessel formation at the edges of this kind of schisis. So doing an FFA and understanding exactly where the issue is, yes, obviously vitreous hemorrhage would not give us a clear view, but wait and watch if the tractional detachment or the detachment is not progressing. Help me in that patient, and we could just manage it just by doing laser within the area of the CNP. So as we treat like a case of proliferative retinopathy or a targeted laser, so that case, so the similar case reports are there in literature where such kind of management can be done. But obviously, yes, if it's non-resolving, then vitrectomy is the only option out.
And another unique thing was she was a female. I have an OCT also where I can document the retinal hole and is being at the level of inner retina. It is reported, though rare.
Okay, correct.
Nice,
So
nice.
very good discussion. So Dr. Sriram is medical officer in Sankarai Hospital, Hyderabad, and congratulations for this beautiful image. So he wins a prize and 2,000 rupees for this. With this, we go to the second winner, Dr. Veer Singh. So Dr. Veer Singh is medical officer in Dr. Sohan Singh Eye Hospital, Amritsar, and this is the beautiful image. Can we see over here? Eid ka chand in the eye, over the retina. It does lie. So he has combined a poetic expression also. So we can see there is a glass foreign body kind of thing which he successfully removed. And this is the text he has given over it. And may I request Dr. Veer, if you are there, can you please enlighten us more about this image? Dr. Veer, are you there? So he was explaining that he will be traveling by air, so he may not attend this to speak about this image. So basically, we can see this is a glass foreign body which he has taken some intra still image and he successfully removed. But in addition to that, the additional fact is it is from a glass vial containing ivermectin and some other toxic injection which had a focal toxic reaction effect on the retina over which it was lying. So he has documented that and done some maybe electrophysiological tests also. So there is not only the surgical efficiency with which he has removed, but also the documentation regarding the toxicity part also. So we would like to hear from our panel if
Hi,
we
Dr.
find.
Chittaranjan, can I just say something?
Yeah, please.
Yeah. So actually, I've seen this case and I've seen the surgical video. So this was a glass foreign body, which is of the base of a ivermectin bottle, which is used to treat parasitosis in cattle. So when the farmer was burning the trash, this thing whole thing exploded and then this went into the eye. So he made a pars plana incision and removed it through a scleral incision. So post-operatively, he saw a toxic reaction, which could be related to the ivermectin toxicity, which was in the base of the vial. And then after removal, he gave intense steroids and all, it resolved. But then later he had PVR, for which again a repeat surgery had to be done. So then from 618, the vision dropped to 6. So it's maintaining at 636 now with the oil inside the eye. So that was what has happened actually the final.
So thank you, CC, for explaining everything, and also to add that he has got probably the best video award in APVRS or somewhere. This is for this video.
Yes, for
So he has
APVRS.
got.
Initially, I thought it was an IOL which was cut before removing it. I didn't expect it was a glass foreign body.
It was glass.
Yeah, looks like an IOL which is made into two pieces to be removed.
Okay.
Yeah. So again, we congratulate Dr. Veer, and he wins 3,000 rupees and a certificate for this image. And with this, we move to the first winner, Dr. Vipin Rana. So Dr. Vipin is Associate Professor in Command Hospital, Kolkata, and this is the image titled Mumps Associated Bilateral Retinitis, for which he wins the first prize for the month of October 2024. May I request Dr. Vipin to please tell a few words about this image. Dr. Vipin.
Good evening, everyone. This is an image of a 27-year-old male patient who presented to us with gross diminution of vision following the history of fever and parotid gland swelling. And the image was taken with Optos, California, the ultrawide this field picture. So it shows this gyrate-shaped cerebriform retinitis lesions, which are there in the posterior pole, this equator and the mid periphery, in the right as well as in the left eye. And the fundus, this fundus autofluorescence corresponding to the retinal lesions shows the hyper autofluorescent areas, and we can also see that these are the perivenural lesions. So the IgG and IgM for the mumps was positive, and the patient was managed conservatively. However, and we in fact searched the literature, and there was a hyperbaric oxygen therapy which was given in the one case. We gave that along with the tablet Valsivir, although which is not a treatment drug of choice. So the patient, however, did not regain the vision, and the vision remained the counting finger close to face. And we searched the literature. There are only 5 reported cases prior to this in the literature, and the 3 are from India and the 2 from other countries. So all the 5 cases which have been reported in the literature were the children, and this was the first case which was seen in the or have been reported in adult patient. Thank you.
Okay, so again, nice description, but sad to know about the poor visual gain of this patient. And what was the opinion of the pediatrician or the physician? Did they advocate anything, any treatment regarding moms you told, na?
So he was managed conservatively only with the tablet paracetamol, and in fact there was an outbreak of the mumps at that time. So just a conservative management, and when he developed the lesions, within 2 days the vision progressed from decreased from 6/6 to the counting finger close to the face. So when he came was referred to us, he was already on the oral steroids, and in addition to that, we added the valcyclovir, and just on searching literature, hyperbaric oxygen therapy was given. But we found that on giving the hyperbaric oxygen therapy, the retinitis lesions, which were almost same for the 7 days, they just disappeared within almost 2 days.
Oh, okay. May I request Subhadra madam to please add anything to this mumps associated bilateral retinitis?
Yeah, no, I just wanted to say that, this any virus, so many viruses, and they can cause this type of reaction. And these are usually autoimmune reactions, just like we see fever-associated retinitis and all. Only difference is, if you see carefully, I hope you have done in the OCT, that these are outer retinal lesions. They
Yes,
are not
ma'am.
in the nerve fiber layer. So they are
Yes,
almost
ma'am.
always, they look like PORN, they look like progressive outer retinal necrosis type of lesion. And that's why some people think that PORN is also some virus associated. Of course, that is Bacillus zoster. So in many of these immunological disorders, either, one is that very quickly it should be treated either by plasmapheresis or immunoglobulins. Those are the ones which can possibly attack and remove all those antibodies which are causing that reaction. But again, many times the patient may not present so fast because those things also work before there is too much of necrosis of the tissues. If at all any recovery will happen, it may take, couple of years for some recovery to happen, if at all. But most of them will lose a lot of it. They can also get optic neuritis, so they can be associated optic retrobulbar neuritis. In addition to this outer retinal sort of necrosis or necrotizing vasculitis, you can say. Very nicely captured, but yeah, most of the patients will lose vision to one of the two. But plasmapheresis or immunoglobulin could be something which can be talked to the infection disease specialists who are dealing with viral etiologies. Because, in like other things like Guillain-Barré or other these virus things, that is what they give. They immediately give immunoglobulins or they give plasmapheresis.
Any role of IV steroid, madam, in these cases?
So people are giving, see, that is the second step. No, all these cases we say that, okay, give heavy dose of steroid, antiviral for what it is. I have few patients of Azure where, very early they presented to me within few weeks. And I have treated them with antiviral and oral steroids and even intraocular steroid, Orzodex. And a lot of them have improved completely back to 2020. But because normally again in Azor, it is thought of like a very poor prognosis condition. And also, I think for any of these conditions, we don't understand everything. But what we do know is that these are immunologically mediated, and the rapidity with which we can neutralize that antigen antibody reaction, either by immunoglobulins or heavy dose of steroids, and if at all there is some antiviral which works on them, or plasmapheresis which removes that antigen antibody complexes, that may be the only chance. Because once the tissue is completely, damaged, then possibly the recovery is unlikely.
So just Chittaranjan, something I wanted to add was the hyperbaric oxygen, which Dr. Vipin had suggested. So each session may be a very costly kind of an affair, but I think Dr. Vipin had the access to hyperbaric oxygen somehow, probably being in the armed forces. Sir, is it? Could you give us just a round figure? Is there that the means as a civilian also we can access to this hyperbaric oxygen?
Yeah, I mean, centers where it has been established, like I'm posted in Kolkata, so I just searched here. So there is only one center where hyperbaric oxygen therapy is there, and it was mainly there because of this COVID time. So they are continuing that. Otherwise, it's very difficult to find it.
So the other thing is that, this there has been a lot of controversy about the mumps vaccination.
Yes.
I don't know if people are vaccinated, will they still get the infection? Of course, the vaccination itself can sometimes cause problem, but I think now the government of India has sort of made it available to the public to get the MMR vaccine, especially for the women, the rubella vaccination. There was a lot of controversy for many years, people not allowing that MMR to be introduced to India for various reasons. That's a long story, but I think it's a good idea for us to know that, we should take as much vaccination as possible. In USA, of course, if I go there as an observer like I went to Boston Children's Hospital, they wanted to see all my titers and all my vaccinations. They asked me for chickenpox vaccination. I said, I have had chickenpox in my childhood. They said, no, no, then you show me the titers. Then before I went, I took all the vaccinations. And recently, my colleague Samira has gone 3 weeks. It has taken for her to get all the serology done. Repeat, she had already got it done here, but they have repeated it there. They're checking, they're asking her to take more vaccines. So I think we are still little far behind. Now my husband is in neurology and infection disease. So he's insisting, and every year I'm taking flu and I'm taking, I don't know what all vaccines. He keeps on telling, take this vaccine, take that vaccine. So I'm taking all those vaccines. So I just say, please take vaccines.
So thank you, madam. We had actually a good discussion on virology and vaccination also. So again,
This
coming to the
mumps also
image,
causes very severe sterility, they can get orchiditis. Did he have any of those symptoms?
Yeah. Ma'am, there were approximately more than 200 cases in the state, Kolkata center, ma'am. And the orchitis was also reported.
They will get, primary sterility. Yeah.
yeah, correct. So again, congratulations, Dr. Bipin, and he wins the first prize, 5,000 rupees. So with this, we move to the images for November 2024, and the third prize goes to Dr. Anjana Miratkar. So Dr. Anjana is currently medical officer in HB Desai Eye Hospital, Pune, and this is the beautiful image. IOL in a wrong place, which has given her the third prize. So Dr. Anjana, can you please explain your image further?
Yes, thank you, sir. Good evening to respected sirs and friends and colleagues. Thank you, VRSI team, for awarding me this for this image. So he was a 65-year-old male who presented to us with sudden dimness of vision, and he gave a history of blunt trauma to the eye a few days back, 5 to 6 days back. And on examination, we could see a dislocated IOL and the posterior pole. This is just a central view of the fundus, but the peripheral retina was on. So we did IOL explantation with parspiral and vitrectomy with secondary IOL in the form of iris color in this case. So this.
Okay. So was it also taken with a contact wide angle
Yes,
lens?
yes, sir. Contact wide angle lens. Yes, sir. This image
So
is
we
taken.
see. Please tell. Please tell.
Yes, sir. This image is taken by contact wide angle lens. Yes.
Correct.
Fundus camera, the IOL may not remain there in front of the macula. It may
Yeah, it will
move down
fall out.
in the vitreous.
What Sisir has
Improper
shown
too.
us. Yeah, correct. So only it's artistically very good image. Otherwise, rest of the management, what she told is very well known and very well done surgery. Anything to add? Any panel for this image?
No, I just wanted to say that the image is very beautiful because, if you see the uh, edge where it is not towards the disc, the other edge, yeah, this edge, it's showing that it is, impinging on the vitreous. So there's enough vitreous there. Actually, you can see that vitreous, especially at the edge, the lower edge. You can see that,
Okay.
it is not on the retina. Actually, there was another picture where we saw that, it was lying on the retina where it was a
Yeah.
vitrectomized eye. Now you compare
Yeah.
that to this one. So this one,
Yeah.
you can see that there's a layer of vitreous, there's cortical vitreous there, so you're safe. And
Yeah.
there is no PVD there. You can actually see it sort of lying on that, impinging on that vitreous. It's very beautifully come up
Vitreous.
here that there is a
Yeah.
cortical vitreous there, and it's not on the bare retina.
Yes, ma'am.
So it's again one compliment on so minutely the image is captured. So again, congratulations, Dr. Anjana, and yeah, she wins a certificate and 2,000 rupees for this beautiful image. So then the second winner is again Dr. Tejaswita Verma. And we can see again similar kind of beautiful image, hemorrhage in wet ARMD. And Dr. Tejaswita, can you please explain further about this image?
Yes, sir. This was also an intraop image taken with the wide field contact lens. It was a submacular hemorrhage secondary to wet ARMD. So a smiling incision was made to evacuate the hemorrhage, and after doing the vitrectomy, core vitrectomy, so it was evacuated with the cutter, with the suction and cutter, and aspirated, and then gas was put, and IV anti-VEGF injection was injected, sir.
Yeah. So any
Sir, there I would
conditions?
like to know if it was a sub RP also, will you do the same procedure? If it is subretinal, it's okay, but if sub RP also, it will not come so easily. So you have to cut the retina, cut the RP, and then try to remove the clot. I don't think clot will come like that. I was just asking.
Sir, it was a subretinal hemorrhage.
I think most people would first do
Gas
anti-VEGF
with
and gas
TPA.
alone without any surgery. Do a pneumoretinopexy with the expanding bubble and either TPA or
TPA.
Avastin, and put the patient face down. A lot of these patients do pretty well. They don't need surgery. Even sometimes it is little old hemorrhage, but it moves out.
Even otherwise also, instead of such a large retinectomy,
Yeah.
a
And
small
then,
subretinal cannula can be given,
yeah.
RD can be induced. Nicely, the blood can be removed
Yeah,
instead
and
of
you can
making
put
such
a
a large
bubble of
bubble
PFCL
of TPA.
to push that out, and then TPA. Yeah, TPA, we usually put TPA through a small 41 gauge
Yeah, 41 gauge needle.
opening where we don't even have to then seal it with laser.
Yeah.
Yes.
So
there is
again,
sorry, yeah. So there is a very nice study from PGI where they have compared a TPA versus saline in a subretinal injection. So even if you do not have a TPA with you, the saline equally works well because it's just creating an extra space so that the blood flows away from the macula, and that's what we want. So
Image
obviously,
is
it's a
good, but it appeared more traumatic.
Yeah, and especially you see that opening, the diathermy and all is going right up to the
close to the
inferior disc margin, where is the papillomacular bundle, where there are a lot of nerve fiber layers which are crowding there. No, it's coming very close to the disc and the inferior part. So it's not nice to try to destroy some of those tissues.
So as we could see, there are discussions about the medical management with injections and other options available also. However, the beauty of this image is
Image
what
is
has
nice.
given, given this award. So again, congratulations, Dr. Tejaswita. Just to repeat, she is a fellow in the Retina Foundation, Ahmedabad, and she gets the second award for this image and 3,000 rupees and a certificate. So with this, the first award goes to the Giriraj Vibhute. Dr. Giriraj is medical officer in MM Joshi Eye Hospital, Hubli, and this is again another image of the bear in the jungle. The hypertrophy of RP. Very beautiful taken image. Dr. Giriraj, can you please describe this image?
Yeah. Thank you so much, sir. Dr. Shishir, I think Dr. Sharath already showed one image of bear track lesion, but I guess in my image, the bear has roamed around a lot more than that image. So yeah, this was a 57-year-old lady, 57-year-old young lady who presented to us just for glasses. And on a routine examination, we found out that on 90D in the right eye, it was seen. So based on that, we dilated her and tried to see what is this. And then we realized that it is bilateral condition and these lesions are there extensively in the right eye and little less in the left eye. So considering these bear track lesions, the patient was sent to a gastroenterologist and the colonoscopy and esophagoscopy was also done. Colonoscopy came out to be normal. Interestingly, she was having a benign esophageal cyst. Somehow that is not, I don't know whether it is related to this or not, but we have observed observation and she has bilateral 6/9 and N6 visual acuity. So that was it.
Again, a beautiful image. There is no doubt about that. For the sake of all our audience, the viewers, I just want to tell one thing. Whenever you see one beautiful image like this, you see, oh, Dr. Giriraj has own and Sarath has own. What will happen to my image? It's not like that. See, the same image. These two people, they have got award. Regarding IOL drop, we see so frequently. See, three people have got. Sama has got, and Anjana has got, Sisir has got. So what I'm telling, similar image also, like Sarath got, but he did not submit both the fundus images. He did something on first OCTA. So just we have to open our brain and eye and ear, everything. Take some beautiful image. Please submit to VRSI image competition. By this, actually, I'm promoting that people should submit more beautiful images to VRSI image competition. Yeah. So again, congratulations, Dr. Giriraj, and
Thank you.
he wins the first prize, 5,000 rupees and a certificate for this. Yeah. So with this, we move to December 2024 images. The third prize goes to Dr. Ashish Kolani. So Dr. Ashish is a medical officer in Chintamani Eye and Dental Hospital, Chhatrapati Sambhaji Nagar. And this is the beautiful image. Again, you see, I was telling you the repetition. VHL disease, very beautiful. The montage he has got so many exudations and the lesions we can see in the periphery. May I request Dr. Ashish to please describe this image.
Hello.
Yeah, tell.
Yes, sir. Good evening, good evening, everyone, teachers and friends, and thank you for selecting my image for this December month. Actually, it's a case of a young male complaining of diminution of vision since a few months, and he lost his one eye since childhood. No any records, but with dilatation, seeing this hard exudation and retinal capillary hemangioblastomas and this exudative RD, with explaining him all the things. Did this CT abdomen also, and it found to have multiple renal cystic lesions in both kidneys, in pancreas, and also in liver. Then afterwards for this treatment, I did the injection of anti-VEGF, and then suppression of this as this decrease of exudative fluid. I did the laser over this capillary lesions, and the patient then referred to nephrologist and for this surgeon for the further treatment. Yeah.
Okay, so thank you, Dr. Assis. Again, we had a very long discussion on this in the initial slides of this presentation. So we are not going to repeat that, but yes, we must appreciate the images, especially the montage taken. And the montage was taken by one of your imaging persons, right? Optom or someone.
Yeah. But the
So we must
montage
thank.
created by myself. Yeah.
Yeah. No,
Yes.
I don't doubt that. So what I'm telling you, it shows
The
that
images taken by optometrist.
yeah, so our involvement and how we should guide them so that they take exactly, the lesion are there over here, inferior part, and he has exactly taken over here. So it's our involvement. We should not be glued to the chair and see the patients. We should
And
move to
also,
our.
it is not a wide field camera, I
Yeah,
feel. So even with a
yeah,
normal
exactly.
camera, with a little bit of time spending, we can get
Time
beautiful.
spending, we can take good
Yes.
image. So again,
Yes.
congratulations, Dr. Assis, and he wins the certificate and 2,000 rupees for this beautiful image. So the second winner is Dr. Anand Temkar. This is again another beautiful image, bilateral macular coloboma. Dr. Anand is medical officer in SKS Memorial Eye Hospital, Coimbatore. Dr. Anand, can you tell few words about this image?
Good evening, everyone, and thank you for giving me the opportunity. So he was a 25 years old male, came with cheap complaints of diminution of vision in both eyes since childhood, as long as he remembers. Vision in both eyes was 6 by 24. IOP in right eye was 12 and left was 14 millimeters of mercury. The serological testing was done multiple times, sir. Both IgG, IgM, toxoplasma, and cytomegalovirus were negative. Now, if we see the images, the patient had sharply defined large yellowish white, coarsely pigmented, atrophic, and round crater-like defect in the macula in both the eyes, sir. So OCT also revealed the disruption of the retinochoroidal complex, atrophic neurosensory retina, and absence of retinal pigment epithelium and choroid in the macular region in both eyes. So that's why we diagnosed him as bilateral maculocoloboma. We have seen few cases also.
So what fundus camera you used, Dr. Anand?
Sir, Mirante, sir. Mirante,
Mirante.
Mirante.
Correct. Correct. So again, for the sake of the viewers, many will be the fellows and residents. One question to our panel, like how to differentiate on imaging modalities these images from the toxoplasma scars, congenital toxo scars. Anything we can differentiate? KCM sir, Divyan sir, madam, Subhadra madam.
Yes, so in toxoplasma scars, usually all the layers are not absent. You can see the choroiditis scar, and it's not like so wide. Mostly it will be like an atrophic scar, but then the other layers you can see, and a lot of times they will have pigmentation, and so that can be seen. This type of lesion where you see it's at a different level, there's an excavation there, which is going even into the whole of the choroid. It's not just at the chorioretinitis level, even the choroid is excavated. I think that gives us an idea that this is a coloboma and not a toxo.
Scar. Toxo scar. Correct. So again, point is very well taken. Pigmentation and preservation of some retinal layers and absence of choroidal excavation, they go more in favor of a toxo scar. And this kind of images we will tell as bilateral macular coloboma kind of picture. So again, congratulations, Dr. Anand. He wins the second prize, 3,000 rupees, and the certificate for this. With this, we move to the first winner again, Dr. Nikhil. So, Dr. Nikhil is medical officer in Jyotish Eye Care, Kannur, and this is the image, impending doom. He has captioned it as impending doom. This is a case of PEHCR, peripheral exudative hemorrhagic chorioretinopathy. And this is the image. May I request Nikhil to please describe about this image?
Thank you for the opportunity, VRSI and the panel members. This is a 75-year-old male patient who is hypertensive for past 5 years, and He has a chronic kidney disease for 1 month. He is on dialysis. Now he presented to our clinic with a history of diminution of vision in right eye for 1 week. On examination and dilated fundus examination, we took this fundus image with the this iodine this iodine wildfield fundus camera. We can see all the sub-RP and subretinal hemorrhages, which is just closing to just with close to macula. He has vision of 612 and in 10 in the right in this eye.
You did not do any intervention, Nikhil?
No, I advised the patient for intravitreal injection, but
No,
he
no.
didn't turn up.
Chittaranjan, impending
Yes.
doom will become a near doom if you do it. Then it
So
becomes
I
hand
have,
movements immediately after that.
yeah, so I have published some results. Actually, in this type of patients, once I was at American Academy and in the Retina Day, they have the subspecialty day. They showed some patients like this and asked the panel, what will you do? And the panel was like, nothing to be done. These eyes are lost. They will become no PL. So move to the next case. But I have published and I have told this before, these patients do extremely well with steroids. I usually give them IVMP for 3 days under physicians, and also control of hypertension is very important. Any hypertensive crisis will worsen. The ecosprin, again, we check with the cardiologist that is it being given for prophylaxis. Sometimes they are taking ecosprin with clopidogrel, which causes more problems. So I ask them that if at all you have to take ecosprin, take the minimum dose, which is 75 milligram per day. That also, if it is really indicated, if they had some stent or they had some thrombosis or sometimes they are just put on the drug. So really, what is the requirement? Because 75 milligram will not cause that much of platelet dysfunction. Most of this happens because of platelet dysfunction. And they do extremely well with steroids. There are reports of some of these cases. How I started giving steroids was because the histopathology of some of these eyes has shown extensive inflammatory cells. And these behave exactly like our suprachoroidal hemorrhage when we do surgery, and sometimes we have expulsive hemorrhage or suprachoroidal hemorrhage. So all this blood is actually within the choroid and in the suprachoroidal space. It's not subretinal. And you can see all those choroidal folds developing. So it is in the choroid. And they do quite well with steroids, which then I taper and keep at 5 to 10 milligram for prolonged time. If they develop vitreous hemorrhage, then also I keep on waiting till they get a good PVD, because in the series that I published, I showed that atherogenic tears are common because it's difficult to make out the plane. And the vitreous is very much because the blood comes from the choroid into the vitreous and there's vitreous adhesion there. So they do extremely well with this protocol of giving a lot of steroids, with which they will settle down. If there's breakthrough hemorrhage, wait till there's a good PVD. Most of them develop cataract also because this blood comes and hits the lens and there's a lot of blood sticking to the lens. So do the cataract surgery, wait for some time, and then in the pseudophakic eye, go ahead and do a core vitrectomy. They do pretty good. They do really good. Sometimes if there's an active lesion, I give Eylea or anti-VEGF, but otherwise most of them do, well with steroids and control of their systemic therapy.
Madam, regarding the dosage of the steroids, you start like 1 milligram per kg body weight or IVMP, then
I
IVM.
usually give IVMP 500 milligram daily once for 3 to 5 days. Of course, it is always with the monitoring of BP, sugar, and the weight of the patient. If it's a very thin patient, I may reduce little. If it's a more elderly patient, again, I may give little less dose. And then after that, I may taper faster. I may not taper weekly. So if I give 60 milligram for 2 days, then 50 milligram for 3 days, then 40 milligram for 1 week, then 30 milligram, I may continue for 2-3 weeks. So that is what I have learned from Dr. Amod Gupta, that whenever you give steroid, give very high dose, and then you can taper it little faster, and then keep a maintenance. And that is what I follow for most of the vulnerable patients.
Yeah, very good, sir, madam. I burnt my hands giving anti-VEGF. Next day morning, patient becomes hand movements, and you try to do vitrectomy prematurely. making a break in the retina, and you believe it will not stop. The bleed will continuously come. Next day morning, even if you put PFCL, whatever it is, AC hyphema will be there, and eye is lost. So
So
don't burn your hands.
this paper was published in AJO, the one I'm telling.
Yes,
It was published in AJO. The title of that was, ultrasonography, B-scan ultrasonography features of IPCV. That's how that paper was published. But in that, I had a lot of case series. Later, we have also published another case series of PCV cases, the effect of steroids.
Then
So
I think
this steroids are required for this type, what I call as posterior bleeding, posterior uveal bleeding syndrome. That is how Yanuzi first described these cases as posterior uveal bleeding. These are different from the classic PCV, CNVM, macular lesions. We are not talking of those small lesions. We are talking of these massive hemorrhagic PDs. These are the ones that I like to treat with steroids. I treat them exactly like you would treat expulsive hemorrhages.
Correct.
Just some point to
Divyans, your
add.
thoughts?
Yeah.
Yeah,
So just
please,
some point
Divyans.
to add, because PHCR is not unilateral and mostly more than 80% would be bilateral. And we can see other eyes, there would be some healed lesions, partly healed lesions, partly active lesions also. Because one eye, as sir is also and madam is also suggesting, that right now it's impending doom, and over a period of time the hemorrhage is going to get involving the macula also. So other eye to be salvaged, and if there are active lesions identified by FFA or ICG, and then do a laser so that
Yes.
we can. But there can be newer occurring lesions. One more thing which one of my cases had taught me was that patients in which, as madam had also suggested, are on blood thinners. These are the patients who develop this and massive, as in this case, also probably checking in INR, because patient would be on heparin because they are undergoing dialysis, and correcting the so correcting the INR would be most ideal, because the other eye is also at risk, as madam is also suggesting. It is like a cross bleeding which is occurring in the choroid, and to stop itself is a very difficult task. Anti-VEGF would not treat it in a way what we think that okay, the CNVM, but it's going to probably actually worsen the issue. So other eye, my obviously this eye still is not lost, so we can manage it as madam has suggested. Obviously, we do not
Please
think of
check
steroid.
if we can give IBMP, that will be really nice.
Yeah.
Okay,
At least
thank
few
you, ma'am.
doses.
So
Thank you,
points
ma'am. We
very
are,
nicely. Yeah. So,
sir, can I talk? Yes.
Nikhil, tell.
We are seeing more cases like this in recent days. Like I've seen 3, 4, 5 cases like this in my OPD. So I was wondering how to manage these cases. Madam has given me a good point. Thank you,
Good.
madam.
So Nikhil, also take the systemic history as madam has told, and all our panel. So we must remember systemic steroids, systemic history, and as Divyans has told, other eye also we need to see, and we should not be trigger happy with anti-VEGF injections, which is very easily available. So we should not go with that. So with this, we are coming to actually the end of this event, the VRSI image competition felicitation event for the winners from July to December 2024. I must thank our esteemed panel, Dr. Subhadra Madam, Dr. KCM Sir, and Divyans. And I must congratulate again all the winners over here. I must thank the VRSI image team, Naresh Sir, Unni Sir, Sangeet Sir, and I am working under their guidance, and Secretary Manisha Madam, and our presidents and all GC members. And one important personnel, actually, the Numeratech team, Sai sir and Manjula Madam especially, they actually help us, because a lot of things goes behind making this PPT and all. So thanks to team Numeratech, and thanks to all our viewers, audience, and I request all of you, please submit good quality images. We have really a good discussion, and also you win some certificate and award. Money may not be a factor, but it gets a lot of recognition and good discussion.
I'm
So
feeling
if
so
any
inspired that I want to now submit images. I have never submitted an image. Sometimes I have told my fellows, please go and submit images. I
please
don't
tell,
have time.
please,
But
yeah.
this is so wonderful. Such beautiful images. I think we have to work hard to first take those images and then submit. We'll do our best. Thank you for
Yeah,
the
ma'am.
invitation.
Yes, ma'am. Like lot of effort goes behind taking all these images. If you see this image also, this may be a wide field
imaging modality, but he has taken different peripheral and things. He has made montage. It's not just auto montage. You would have tried it.
Yeah, and the
So
three-dimensional effect is so good in this. You can see the
yeah,
synergy
yeah,
attachment, the
correct.
multiple choroidal folds. It's very nice.
So again, congratulations, Nikhil, for this, and congratulations to all the winners. So if there is no other comments from anyone, we will close this meeting. So thank you, everyone.
Thank you, thank you,
Chittaranjan.
thank
Thank
you.
you, ma'am.
चलो सर, अभी
Thank you.
फिल्म
Good
देखने
night.
जाना है, बच्चे फोन कर रहे हैं, छावा देखने जाना है।
Okay.
Good man. Have a nice time,
Have a
ma'am.
nice time,
छावा
ma'am.
देखने
Thank you.
जाना है।
Have a nice
Sure,
crying.
ma'am.
Bye,
After
Mandia.
movie, everybody is crying.
हाँ, 11 बजे छावा। चलो।
Okay, ma'am. Thank you. Thank you,
Okay.
Divyan. Thank you, KCM sir. Thank you, madam.
Thank you, Chittaranjan.
Yeah.